Hello and welcome to the recording on multiple sclerosis. Today's lesson on multiple sclerosis will be presented in the form of an unfolding case study. During this case study, we'll review the pathophysiology of MS, we will look at signs and symptoms, and we will also look at treatment options, as well as things that can exacerbate or cause it to, well, really just things that can exacerbate. So, the client or the patient in question is named Casey. Casey's a 21-year-old nursing student who saw her PCP a week ago for complaints of fatigue, double vision, weakness, and poor coordination. An MRI scan of the head was ordered by the PCP, and Casey was instructed what to expect from the procedure. So now we're back, and she's in her PCP's office, sought to learn the result. Comes with her mother, and the PCP tells her that she has multiple sclerosis and she doesn't know anything about it. So she says to you, "What is it?" And you say, what do you say? You say, "What is the pathophysiology of multiple sclerosis?" And MS is listed in the textbook under mobility, but it's actually being taught under immunity because of the pathophysiology of multiple sclerosis is immune mediated. Okay? And it involves an immune cell attack on the myelin sheath around the nerve cells. So this goes back to that basic anatomy and physiology. And you know the myelin forms a fatty insulated layer around nerve cells to increase the speed of electrical transmission along the nerve. Symptoms occur because now you've got decreased transmission of nerve impulses. Okay, there are multiple types. For the purposes of this class, you don't need to know the specifics. The most common type is the relapsing remitting multiple sclerosis, which means that people will have times where they feel relatively okay and normal, and then they're going to have times when they have a flare-up of symptoms. This happens as well with lupus. As far as epidemiology and risk factors, okay, once again, with autoimmune, because that's what this is, you have to think about that they really don't know all the reasons why the body attacks itself. However, epidemiology and statistics show us that women are 2 to 3 times more likely to get the disease. If you have a family history, then you know that there's a genetic risk of developing MS. Caucasians tend to get MS more than other ethnicities. Interestingly, if you look at the chart, the red and the purple, red is the highest risk of MS, and purple is the next highest risk of developing MS. You see a pattern there. I see a pattern there. It seems to happen with those living in northern climates. They haven't made a specific connection with it, but there may be something having to do with vitamin D deficiency. I don't know. There's a lot out there, and they have not come up with any specific good scientific evidence to support that, but it does bear watching because you can see there's definitely a geographic link to the development of MS. Sometimes autoimmune diseases are provoked by some kind of infection. So an infection stimulates an immune response, and for some reason in susceptible individuals, it will stimulate an autoimmune response of some sort. If someone has migrated, if you move before age 15, you assume the risk of the place that you've migrated to. If you move after age 15, you retain the risk. Your risk stays fixed in the country that you grew up in. So that tells you something as well, that it may be related to where you grew up and the environment and the geographic area that you grew up in. So let's talk about clinical manifestations associated with MS. And I'm going to give you a second to look at this. It's your favorite thing in the whole world. Select all that apply. So, of the following, which are clinical manifestations associated with MS? In your textbook, on page 877, on the right side, right column, it has a whole big thing of common symptoms of MS. Okay? So for this case, depression, numbness, visual disturbances, loss of balance, pain, and cognitive changes. Right. Let's take a look at this. And this shows you the different symptoms and the prevalence. So numbness and tingling, fatigue, muscle spasms, and difficulty walking are by far your most common. lack of coordination and balance, unsteady gait, tremors, bladder dysfunction, and bowel dysfunction. Generally, the bowel dysfunction takes form as constipation. The bladder dysfunction can be either urinary retention, or could be also urinary incontinence. Visual problems. So you can have problems with loss of vision, double vision, blurred vision, color distortion. There's sexual dysfunction, problems with speech and swallowing. As you can see, there's quite a few, as well as emotional changes. There can be depression, there can be other emotional changes, and some people will also have a decrease in cognitive function. So they may have difficulty in concentration, difficulty with judgment and reasoning. So as you can see, MS has a variety of things. You may not have all of them, but there's a lot of different things that happen because remember, we're dealing with nerve transmission. And you'll remember at the beginning of the case study, the doctor ordered an MRI. And so that tells you that one of the diagnostic things they look at is MRI. And patients with multiple sclerosis have very classic changes on MRI. Okay, so your options are increased CSF, atrophy of gray matter, multiple plaques, or inflammation of the basal ganglia. And the answer is multiple plaques are located throughout the central nervous system. So they don't know why that happens, but MRI is the go-to diagnostic. There's no single test that can be used to definitively diagnose it. So they look at medical history, physical exam, and they'll do an MRI and look for plaques. They may do a lumbar puncture to examine the CSF to see if there's immunoglobulins in there or antibodies. Okay, they can do different types of myelograms to look at muscle response to nerve stimulus. Okay, and they also can rule out infectious and inflammatory diseases that may be causing the MS. So let's look at treatment goals because this is where a lot of your nursing care comes in. And ideally, you want to treat the symptoms, manage the relapses, try and modify the disease course, reduce disability. In other words, maintain functionality and independence as long as possible, manage symptoms, and optimize quality of life. So that's the plan. Symptoms are going to drive some of what we do. There are two different disease-modifying drugs I want to address. One of them is glatiramer, also known as Copaxone. And it specifically blocks the immune system attack on the myelin, so it's a direct It directly affects the pathophysiology, and we're going to have a question on it later in this. There's also beta interferons. They reduce the number of inflammatory cells that cross the blood-brain barrier, so it's going to reduce the amount of neuron inflammation. They can slow the progression of disease and decrease the severity of the attacks. So there are some things. Both of these medications are injectables, so you need to know that's something that is key as it comes to treatment. If the patient is struggling with bowel constipation, they will start with Docucy. Probably not going to want to go onto a long-term regimen of stimulant laxatives because of the risk of dependence. For muscle spasticity, they can look at baclofen, which is Lioresal, Lioresal, or diazepam. They also can look at some of the other muscle relaxants like cyclobenzaprine, which I believe is Flexeril, and Cariprazole, which is commonly known as Soma. For bladder dysfunction, especially urinary retention, they look at oxybutynin and prazosin. Prazosin is an alpha blocker, so because it's an alpha blocker, you would expect a side effect of decreased blood pressure. For fatigue, they look at neurotransmitters, so they look at things like fluoxetine, which is an SSRI, and it's going to increase the availability. I think it's an SSRI. It's one of the reuptake inhibitors, I know that. Pain, they look at things like gabapentin and pregabalin, which deal with neuropathic pain. Tegretol, which is carbamazepine, is also an anticonvulsant that can be used for neuropathic pain. And clonazepam. Clonazepam is a benzodiazepine that also tends to help with muscle spasm and muscle pain. For erectile dysfunction, you have the Afils. So the PCP orders glatiramer 20 milligrams subcutaneous daily, and the nurse educates her on the correct administration for the drug. So putting these things in order. Right, so look at that, and the first thing you want to do, okay, if you want to work this out, I would tell you to pause the video, do it, and then come back. First thing you want to do is you want to look at the medication. So number 5, inspect the medication to ensure that it's clear and colorless to slightly yellow. Because if it's not, then you might as well not proceed with the rest of the steps. So inspect the medication, then you allow it to warm to room temperature. So 5, then 3. Then you are going to choose your injection site. 1, clean the site with alcohol and allow it to dry. 4, pinch the skin and inject at a 90-degree angle. And 2, discard the needle in a puncture-resistant container. Potential side effects of a disease-modifying agent, injection site reactions. So because both of these things I talked about, the beta interferons and Copaxone, are injectables, you have to worry about injection site reactions. You may also have problems with your immunity. You may have problems with your immune system and how it responds to things. And you can always have the always popular nausea, vomiting problems as well. So true or false? With MS, you should avoid cold temperatures and activities. Achieve a balance between rest and activities. Well, we know that that's true. Okay. Do you want to stop all medications if fatigue becomes severe? No. Maintain a healthy lifestyle and avoiding alcohol and smoking. That's true. As far as cold environments, generally you want to avoid extremes of temperature. So this is where keywords come into play. So if it's cold, it may exacerbate it may exacerbate the symptoms. So different things that can cause exacerbations are listed in your book, and I just have to find them now. And of course now I'm not going to be able to find them. Okay, on page 881 it kind of talks about it a little bit, and I believe ATI talks about it. Certain things are going to cause your symptoms to come back and be a lot more evident. One of them is stress, increased body heat, so generally you want to avoid hot baths, infections, fatigue or lack of sleep, and this is one of those. Fatigue can cause an exacerbation, and because of the exacerbation you're going to feel fatigue. So it kind of happens before, it happens during, it happens after. Smoking also can exacerbate. It's important to tell the patient to maintain a healthy lifestyle. Eat a balanced diet, maintain adequate hydration. Okay. Fever, which is part of increased body heat and infection, can also be a cause for exacerbations of MS. Okay. Different nursing diagnoses. Certainly you have mobility to consider. Okay. If the patient is having difficulty swallowing, you may have to have something along the lines of risk for aspiration or impaired swallowing. Fatigue. Okay. Self-care deficit potentially if there is a problem with ADLs. So there's quite a few you can look at. Things you need to do to promote mobility: frequent short rest periods. Daily exercises for muscle stretching. Okay, number 4 I'm never sure about because it's a warm environment. Tough to say. You don't want to be in a cold environment. You don't want to be in a hot environment. Walking is good. You don't want to take hot baths. And that concludes this PowerPoint on multiple sclerosis. Thanks so much for your attention and have a great day.